process. They may not know how to do it, and a lot of I know that probably all of your organizations have something to help these individuals navigate that system, and our hospitals as well, where they have these dedicated enrollment outreach workers to help them walk through and fill out that application for them in some instances. But whatever that we all can kind of do to help make sure that everybody who is eligible actually signs up will be key.
One of the things that we appreciate about Medicaid today, one of the few things we like about it, is that in Illinois, which is where we work, they'll go back and pay for expenses incurred up to 3 months before the date of application. Will that be true with the exchange programs, do you know?
I don't know.
That would be.
Yeah, I mean, the good news is the regulations on these exchanges aren't out yet, so when they do out, you all should comment on that aspect. Yeah.
Is this your last slide or which slide?
Oh, I have a lot.
Oh, okay.
What how are we doing on
I
time?
wasn't sure if
How are we doing on time?
We'll just continue asking you questions.
Yeah, no, definitely. The next couple of slides on coverage, I'll go over a little bit quicker because it's not the huge Medicaid one. So the next one is on state-based exchanges, and we talked about this a little bit. Initially, they were envisioning small businesses, employees and individuals can buy off of the plans off of the exchange, and these are 50 to 100 employees. By 2017, it'll be open up to larger businesses. I mentioned the premium credits and cost-sharing subsidies for individuals from up to, if you're not Medicaid eligible, then up to 400% of federal poverty level. And as with everything, there are additional details on it. But I think the main point is that you're going to have this marketplace where ideally it'll be easier for people to go and be able to know what they're qualified for. And the next slide kind of gives you a sense of what these exchange subsidies are. Not the subsidies, but this is a premium, so how the subsidies will affect you. So the left-hand column is for a single individual income. These are from 134 on top all the way down to 400% of federal poverty level. These are based on 2009 poverty guidelines. This is what if your premium is larger than 24, then you'll get some sort of subsidy to bring you back down to.
Those are pretty steep increases.
They are. This is a thing that we also learned is from talking to our members. If you really look at these premiums, the current population that they take care of can't afford this. So the idea is, we'll cover people up to 133% of Medicaid, and then we'll give subsidies to folks to go and buy plans on the exchanges. It really was a compromise. I mean, in the earlier health reform debates, there were talk of, I think the initial option out there was to actually expand Medicaid to 400% of federal poverty level. Now, clearly, that would have cost many trillions of dollars when at the end of the day when CBO was estimating it. And when it came close, it's not there's no policy rationale behind it, but they didn't want a price tag attached to the Affordable Care Act that was larger than $1 trillion. So that made that was the reason why a lot of the great coverage expansion stuff was that scale back. So when you had to scale back from 400% down to 133, then you say, well, what do you do with this population who's still very low income but not super poor that they will be in Medicaid? Then we're going to give them some subsidies. And again, the level of subsidies also bumped up against that. Didn't want the price tag to be above $1 trillion. So this is where they settled that. But when it comes to implementation, we very much realize that this is unaffordable for many. You forget about what the federal government has set as here's what we think is an unaffordable provision. Therefore, if that's the premium for you, then you don't need to comply with the individual mandate. This is something within the individual mandate, and I think it's still very unaffordable for lots of current folks. Yes.
But just to make sure that I understand this anyway, the maximum monthly premium is attached to a fixed schedule regardless of what the premium for the product actually is. So that if healthcare costs go up by 15% a year for 10 years or whatever, you're still going to have this sort of a limit on your own exposure as opposed to paying a percentage of the premium cost.
It's a dollar amount.
Right.
And what I'm not exactly certain is whether that dollar amount is set to some sort of growth rate, a very modest one or not. But you're right, it is a dollar amount. And the other piece to what you're talking about is if healthcare costs rise by 15%. The other piece of what we don't know is actually what those premiums are on the exchange. I mean, we talked about this bronze, silver, gold, platinum plans or levels of benefits, but we have no idea what those costs are yet. And without the exchanges sort of, they don't exist other than in Massachusetts and Utah right now, and those are completely state-run, not outside of the Affordable Care Act. It's hard to tell in a local market what the rates would be.
So, but again, the premium maxes were set based upon income, not upon the cost of the
Right.
healthcare benefit.
Is that family income?
Singles, these are single.
So if you have 2 adults and a child, the premiums are gonna be double that.
Do you have what that's for a 4-person family?
I'm not sure, but I can double check and get back to you guys. I mean, I think logically, I want to say yes, but I can double check on this.
Yeah, I'm just trying to figure out what is the burden on the yeah.
So, so this would require that everyone who's currently uninsured would, and who isn't 133%, would be required to pay this amount of money per month without regard to their income. I mean, if you're making $27,000, paying $183, that if they can't do it, are they? Yeah.
Well, these premiums are, the answer to your question is yes. These premiums were set under the limit. Now, there is a limit that I mentioned earlier where they say if the premium is above an X% of your income, then it's determined to be,
Is it 8%?
I think so, yeah, that it's determined to be unaffordable for you, therefore you won't get the penalty if you don't actually buy insurance. These are under that limit.
So help me figure that, go ahead.
Because in Massachusetts, for instance, now, basically, if you can't afford to purchase through the exchange, on your taxes, you pay a fine of like $3,000 a year or something.
That's how they assess the penalty there.
Right, and I guess, is that how it's gonna be at the federal level? And I'm also curious does
is a
that
penalty on your
$3,000
taxes.
go into free care? If you show up at the hospital, you're uninsured, you should be insured. Like, what's gonna happen to the pool of dollars going to subsidize the uninsured that aren't through Medicaid or
Great question. And in Massachusetts, there was a pool, a physical
Right, there was a great
there.
pool there.
And that pool was drastically reduced as a result of their health reform. And I guess the equivalent federal pool, though there is no pool to say per se, it would be the Medicaid disproportionate share payments that I mentioned earlier, as well as some of the other. Medicaid DISH is the main one, but there are other supplemental payments that are meant to cover the cost of the uninsured. What's happening in federal health reform is that Medicaid DISH payments are slated to be reduced starting in 2014, and then CBO has estimated that from 2014 to 2019, the reduction is in total $14 billion. So to give you a little bit of a sense, Medicaid DISH, the federal government kicks in about $10 billion a year on Medicaid DISH. It's part of the Medicaid program, therefore there's a state match, or in our members' circumstances, their match that's making up the difference. So they're reducing the program starting in 2014, though the large cuts will come in 2017 and beyond, and then those cuts will be sustained going forward into eternity for as far as we can see. And then on the Medicare side, there's also a DISH payment. Medicare DISH is a little bit different than the Medicaid DISH in that the way that it's figured, it only takes into account low-income Medicaid patients. It doesn't take into account the cost of uninsured. And currently, Medicare DISH isn't that targeted. So when I think MedPAC looked at this, did the study of it, where they basically looked at a hospital and compensated care level, how much Medicare DISH dollars they receive, and there was no correlation or relationship between anything. So you can have a hospital with off-the-charts uncompensated care; they get about the same Medicare DISH as everybody else. And also number-wise, there's about 5,000 hospitals in the U.S. About 1,300 qualify for Medicare DISH. It's a really large number of hospitals divvying up that pot of money.
So what's the fine that somebody would pay if they don't enroll?
It's
Like $600?
Yeah, that's what I want. It's like $600. It's not a lot, and that's part of the
Per
other.
year.
Well, it's not a lot. It's all relative, right? But I think it's large enough to incentivize some people to actually go and buy insurance. So,
So
like you
I'm
said,
looking
they'll
at
end
this,
up-
you know, so if I'm just above 200% of the federal poverty level, my premiums are gonna be almost $1,400 a year. And if I'm a young invincible, I'm gonna pay the 600 instead of the 1,400. That's why, you know, I know I have to go back and write a letter about that retroactive enrollment, because then if that person does crash his motorcycle or get a sexually transmitted disease, then he can sign up,
Right.
like he could with Medicaid. And that would be a huge way to reduce uncompensated care.
No, and you guys are bringing up a good point. And I think I have prefaced everything by saying if everything was implemented perfectly, right?
Yeah.
There are all these things when you really take it down to the local and patient level, is it may not work as, you know, policymakers sitting in Washington trying to make it, trying to think that it's going to all shake out this way. And at the end of the day, whether it's you're working with the patients, we are incurring the incompensated care. It's a huge concern for us. For example, if in not just in 2014, but if the take-up rate for Medicaid, the Medicaid expansion, as well as for any of the plans on the exchanges, isn't what they estimated, and yet the the Medicaid dish dollars, the reductions are, there's a hard number, so it doesn't matter what happens on the coverage side, there's a number that's gonna be reduced. So what happens if people don't sign up soon enough, and we still have the uncompensated care, but the dollars are gone, like in Massachusetts, you know, I think.
Well, so as communities, we have to do a really much better job of getting people into Medicaid.
Yeah, and that's where the enrollment and outreach efforts is key, to make sure that everything shakes out like everyone wants.
Just an observation and question, and maybe our friends from Canada might want to comment.
Yeah, they're quite quiet.
sitting here
Kind of
trying to We've got a deal for you.
Being in the profession that you are, I mean, and most people, the things I read, I mean, the inevitability of some kind of universal healthcare coverage in our country, just like in other developed countries, is inevitable.
Will we be young enough to enjoy it?
No, we probably won't, I don't know, but I mean, this will not be, I mean, this is not gonna be manageable. I mean, no one will understand it, and I just am curious about being in the profession that you're in and the knowledge that you have. What is your impression, and I would be curious about hearing from people in Canada in terms of what's the discussion in their country in terms of dealing with this issue, particularly as the population ages. What is beyond all this?
Well, so personally, I'm left speechless. You
Yeah.
know, and I'm originally from the U.S. and I've been fortunate to live in Canada for 22 years, where I've experienced universal health care. I just can't believe the complexity of this. I don't even know if I would be able to figure out, you know, where do I go? And I just go back to the whole point of why wasn't one government plan pushed? Because that's what we have. Yeah. And I just find this breathtaking.
Because the doctors lobby has done a great job of incorrectly, I think, painting the Canadian system as bad.
Well, that was back when Clinton tried to do health reform, and the AMA was out there scaring everybody about that. This round, AMA nationally at least supported health reform, and it caused some rift
Public
within their.
action.
They supported coverage expansion, whereas they weren't supportive of any health reform in
Before,
'93.
right.